Welcome to About a Woman, the podcast which looks to take a deep dive into meaningful issues that affect women's health. I'm Dr. Katie Cowie, and I'm a GP and women's health specialist, founder of the Women's Health GP, and passionate about educating and empowering women on their journey to a place of wellness and positivity.
So today we've decided to turn the lens and you get two Katies for the price of one. My name is Dr. Katie Massey and I am a GP and former colleague of Dr. Katie Cowie. So this is a great opportunity to learn about menopause and to hear about your experience in this field. So firstly, could you just tell us a little bit about your journey into women's health and kind of what made you interested in this topic and how you've become the expert in this field that you are at the moment?
So I've had quite a long and kind of tortuous route into medicine generally, and then into my chosen specialty, to be honest. I initially trained in law, so I did a law degree first, and then it was during that time when I was doing my law degree that I did a specialist module in medical law and ethics, and it got me really interested in medicine. And I'd studied, thankfully, science subjects at A level, so it felt like a relatively natural transition, but being a bit of a glutton for punishment, I then decided to go on and study medicine. But because I'd done a science degree before, I had to essentially start from scratch and do the full 5-year medical degree. Um, and then I went off to do my houseman years in Nottingham and kind of rotated around lots of different specialties, and one of which was obs and gynae. So that was kind of my first real kind of practical exposure to women's health.
Mhm.
Um, and I then was at a crossroads point where I had to decide about what I wanted to specialize in, and I wasn't 100% sure at that point. It felt like quite an early stage to have to make that
Yeah.
decision. And I decided at the time to go and train in pediatrics. So I went down to London to do that, and I rotated across all different departments, pediatric departments across London, north of the Thames. So a lot of the big kind of central hospitals. And one of the things that I did during that time was a lot of neonatal care, because there's a lot of neonatal
Mm.
departments in London. And part of our role as neonatologists was to help support the postnatal process. So a lot of women would have
Yeah.
babies with feeding difficulties, obviously premature infants, etc. And so again, I was getting this exposure to also caring for women in a way, because I was having a lot of those conversations with the mothers,
Yeah.
and I really loved it. And I just had this itch that I couldn't scratch really within the
Mm.
specialty. So I did a few years of my run through post and then decided I wanted to come out and explore women's health a bit further. And I toyed with the idea of going back and training in obs and gynae,
Mhm.
but decided eventually upon going into the community. So I trained as a general practitioner, and I started to hone this interest further in women's health. I was getting exposure to a really broad breadth of issues, which were women's health related, and menopause was one of them.
Yeah.
And eventually, after I'd qualified as a general practitioner, I got the opportunity to go and work for a very large menopause clinic
Mhm.
in the private sector, and I took it. And at the beginning, I was pretty inexperienced, to be honest. I'd done a course, which was kind of a prerequisite to applying to that company. So I'd done their course, which I'd really enjoyed. And I had a lot of supervised support in the early stages of my training, which was great. But I very quickly got a lot of exposure to menopausal women. And that came in all different guises. So there were some women who were relatively straightforward in terms of the care that they required, but we also got a lot of complex cases. So women who had um, complicated past medical histories,
Mhm.
maybe have had hormone receptive breast cancers in the
Right.
past, maybe had clotting disorders,
Mhm.
things like that, which required extra special
Yeah.
skill sets. So that was really great, because I was getting great variety, but
Mm.
also a great volume of women coming
Mhm.
through the door. And I decided after that to go and train with the British Menopause Society. So I did that and had a fantastic supervisor, and learnt more and more and kind of accumulated a lot more knowledge during that time. And I got certified up to advanced level, and then eventually got accredited by the British Menopause
Mhm.
Society as a specialist, which is kind of like the sort of top rung you can get to in terms of
Oh, wow.
qualification
Yeah.
in the menopause. Um, and but alongside that, I decided I want to kind of hone skills more broadly in women's health in a specialist context. So I did a diploma with the Royal College of Obstetrics and Gynecology. So that was much more broad stroke. We did
Mhm.
lots of different areas of women's health, and again, it really upskilled me.
Yeah.
And after I'd done all of that, I decided finally I wanted to set up my own clinic, which kind of gave me the autonomy to kind of tailor women's care the way that I wanted to.
Yeah.
Um, and yeah, so I now have a clinic that is based in the East Midlands.
Mhm.
I do a lot of face to face appointments for women in the local area, but I also have facility to do video consultations. So I have women all over the country who I consult with, particularly for advanced menopause care.
Oh, great. So it's taken you many years then to get to where you are now.
Yeah, absolutely. Yeah. Yeah. So it's been a slow and, as I say, slightly tortuous process of decision making, but
Yeah.
I feel really fulfilled in what it is that I do now, which is
Yeah.
great.
And I imagine you make a huge difference to the women who you see in your clinic. Do you get feedback about that or?
Yeah. So, yeah, I've been really fortunate in the feedback that I've had to date. And I suppose it's one of the things about menopause care and women's health care at large, which is really satisfying. The fact that you can really transform someone's life. You
Yeah.
can really um, take women from a place where often they're feeling quite desperate, and they've
Yeah.
possibly met a lot of closed doors along the way,
Mhm.
really struggled, and get them to a point where they feel that they've got a good quality of life
Yeah.
and that they're coping with the demands of life and everything. And that's just a really great feeling.
Mhm.
So I find that really satisfying.
Yeah. And it's quite a vulnerable time as well, isn't it,
It
for
is,
people?
yeah, it is. And I think often women come with really unanswered questions and yeah, particularly if they're feeling very emotionally dysregulated,
Mhm.
or they're having horrible cognitive symptoms, or that they're in a lot of pain,
Mhm.
all of these things, yeah, it makes you feel really vulnerable.
Yeah.
And it needs a lot of care and it needs time as well, which is one of the critical things that I think often we're a little bit lacking in time within the NHS
Mhm.
system at the moment. Things can be quite pressured.
Yeah. Would you mind telling me a bit more about what the services are that you offer at the clinic and a little bit more about that?
Yeah, sure. So, a lot of my work, unsurprisingly, is in advanced menopause care. So I describe it in that context because what I do is very in depth. I spend a
Mhm.
lot of time with my women and we kind of dissect everything in detail. And I do deal with women who have medical complexities as well, who maybe thought that perhaps hormone replacement wasn't an option for themselves before, but were keen to explore it.
Mhm.
So I do a lot of that, and included within that, I do testosterone replacement as well, which is often something that's quite of interest to women now when
Mhm.
they're sort of exploring their options where hormones are concerned. But as well as that, I have a special interest in weight management in
Mhm.
menopause, and the kind of metabolic effects of
Wow.
hormone deficiency. So I run a service which is specific to
Mhm.
that. And I also have comprehensive women's health checks. So a lot of women book these as a kind of annual checkup. So it's a bit of an MOT, really, but it's also an opportunity to air any specific kind of concerns they have about their health. So I do that. And then I have women's health focus appointments, and that's the more broad brushstroke in a sense. It gives women an opportunity to make of that consultation what they want to an extent.
Okay.
So the kind of things that that would cover would be um, premenstrual symptoms, so PMS, PMDD. Um, I have women coming with a background of endometriosis and wanting to have kind of first stage medical management. Have women coming with polycystic ovary syndrome,
Mhm.
wanting some support and to explore the options where medication's concerned. Um, I deal with women who have got breast concerns. I do breast checks.
Mhm.
vulvovaginal concerns. Sometimes, if women, for example, are already established on HRT, but they're having soreness, dryness,
Hmm.
itching down below, or they've found a lump down below, they might want to come for assessment about that specifically. So, all of that is kind of covered within a women's health focus appointment. So, it's quite varied, actually,
Yeah,
what I do.
and broad
Um,
as well.
it is quite broad, and hopefully we'll come on to it a bit later,
Hmm.
but I have some plans for the future as well, in a way that I want to expand further to add in some additional services.
Okay. Oh, that sounds exciting. So you've kind of touched upon the menopause earlier and some of the cognitive issues. Would you mind just, for everyone listening, just to describe what the menopause is and what's happening in your body and a bit more background to that?
Yeah, sure. So effectively, what happens during menopause is, in real terms, you're sort of running out of follicles. So, follicles is kind of the medical term for your eggs, really.
Hmm.
So, every woman is born with a set number of eggs. Some women have more eggs in their ovaries when they're born. Others have less, and the rate of decline of eggs varies from one woman to another as well. But all of us eventually get to a critical point where we don't have enough follicles to be able to produce sufficient reproductive hormones for our needs. And that's effectively what's described by menopause. Now, menopause in strict definitional terms would be where you've gone a year without periods. And the average age of menopause in the UK is 51 years, but there's kind of a normal accepted range of between 45 and 55 years for that. Women whose periods stop between the ages of 40 and 45, we term that as an early menopause. And if you have a situation where your periods have stopped before the age of 40, then that would be termed premature ovarian insufficiency.
Hmm.
And it's really important that we don't miss those patients, because potentially they could be exposed to reproductive hormone deficiency for much longer.
Yeah.
So, in terms of the health implications, it becomes more serious again, really, for them.
Okay. And is that sometimes genetically determined or is it completely
Yeah,
sporadic?
so we certainly see that there can be a familial predisposition to
Hmm.
early or premature menopause. So we do see that where it's running through the maternal line. But one of the big drivers, we think, for premature ovarian insufficiency is autoimmune disease. So
Okay.
often you find that those patients will have um, pre-diagnosed autoimmune history. So whether
Hmm.
that's things like inflammatory bowel disease or thyroid disease or psoriasis, or of course there are so many different types, aren't there, affecting different systems within the body. But we often find that there is something there. And sometimes it hasn't been diagnosed yet, or it presents itself later. But it's always worth bearing that in mind with patients who present with premature ovarian insufficiency, or POI as we call it,
Yeah.
because sometimes we like to screen for signs of autoimmunity in those
Oh,
patients.
okay,
Mm.
that's interesting. And in terms of the symptoms, so you talked about from a kind of biological aspect, what's happening in the body. What might those symptoms be that a woman's experiencing?
Yeah, so I kind of broadly like to divide them into physical symptoms, cognitive symptoms, and emotional symptoms. And the most well known actually tend to be the physical symptoms.
Mm.
So traditionally, we always used to talk about hot flushes and night sweats. So the medical term for that is vasomotor symptoms. And that's where the thermoregulatory center in the brain is being affected by the reduction in estrogen levels, and it presents itself in that way. And so that was the kind of traditional model of how we were presented with menopause. It's
Hmm.
all about vasomotor
Yeah.
symptoms. There are other physical symptoms. There are things like headaches. Often patients who have a history of migraine, they tend to find that their migraines will often get a lot worse around the time of
Mm.
menopause. But we also have patients presenting with headaches who have never considered themselves a headache person before, but suddenly headaches have become a problem for them, or they've got new presentation of migraine. So we see
Okay.
that. We see dry, itchy skin. A lot of women complain
Mm.
about that in a generalized context. And we know that estrogen is very involved in the barrier function of the skin, so the production of the sebum, the natural hyaluronic acid,
Mm.
etc. So once that becomes lacking, that barrier is not so robust. So we certainly see that. And some women will have symptoms that are not so traditionally associated with menopause, but would still count as physical symptoms. So things like um, they can be neurological symptoms,
Mhm.
so tingling sensations. Sometimes women describe it as like a crawling feeling under the skin,
Mm.
which can be really distressing.
Yeah.
Um, and then we have what we now term genitourinary syndrome of menopause, which is effectively symptoms down below. So
Mhm.
it's vaginal symptoms and vulval symptoms. So that can be dryness, itching, soreness, and also urinary symptoms fall within that umbrella term as well. So we find that estrogen affects the contractility of the bladder. You can get pooling of urine in the bladder, which can then predispose to urinary tract infections. So that
Mhm.
often becomes a problem. Often have women really suffering with that in a postcoital context. So they
Yeah.
come saying, every time I have sex, I seem to get a
Yeah.
UTI or cystitis afterwards, which again can be really
Yeah.
unpleasant and really distressing. Um, and the other one that we see a lot on a physical level is aching and soreness of joints,
Mhm.
stiffness of joints, women getting up in the morning and feeling almost robotic with their
Yeah.
movements. Actually, I tend to find that's one of the things that responds really quite quickly and well to estrogen replacement. That's often one of the early reliefs
Mm.
that we can give by commencing on HRT. So they're kind of your physical symptoms. But interestingly, the symptoms that women often come to present to me
Mhm.
with as a menopause specialist are more cognitive and emotional.
Yeah.
So I do sometimes see women with intractable vasomotor symptoms and really awful musculoskeletal symptoms, but I'd say the majority of women are presenting more because of the cognitive and emotional effects. So we know that there is a really close interlink between estrogen and the neurotransmitters that exist in the brain. So by that I'm talking about things like dopamine and serotonin.
Mhm.
So, for those who aren't familiar, you have neurons in your brain, and the neurons make connections and they communicate with one another through these chemicals called neurotransmitters. And those neurotransmitters are involved in your ability to regulate your emotions. They are involved in your ability to forward plan, for you to
Mm.
concentrate, for you to retain information, so for your memory function, but
Yeah.
also for memory recall as well. So often what we find is that those neurotransmitters get dysregulated in the same way that the reproductive hormones get dysregulated during that time. And so classically, women will come on an emotional level. They're often feeling anxious. They're
Mhm.
often feeling low. Sometimes that can lead to suicidal thoughts. So that's not uncommon,
Mm.
sadly. Irritability and rage is really, really common. We often have patients presenting for the first time with PMS symptoms. So they have these kind of cyclical mood
Mm.
disturbances, which can be really disruptive. And for women who have more entrenched patterns of PMS in their kind of premenopausal life, they often find that those PMS symptoms get worse as well.
Okay.
So that's the kind of emotional side to it.
Yeah.
Um, from a cognitive perspective, I mentioned about memory recall. Often patients will come, they are worried that they're suffering from the early stages of dementia, which can be quite
Mm.
frightening.
Yeah.
They're finding they're doing things that are completely out of character. So, for example, leaving your keys in the fridge or leaving the door
Mm.
unlocked, or things that sometimes make them feel actually quite at
Yeah.
risk. They're finding that they're struggling to recall the names of people who are really well known to them,
Yeah.
struggling to put sentences together as well, and to kind of actually express and convey their thoughts.
Mhm.
And that's really problematic, particularly for women who have sort of high powered or
Mm.
highly pressurized jobs. And actually, a lot of women at the point of menopause are in positions of responsibility in their
Yeah.
work as well as their home life. They are at a point where they have a massive skill set to offer, and then suddenly they're not able to convey their ideas in the way that they did before. And that can be incredibly frustrating mean, I've dealt with CEOs, very high functioning lawyers, doctors, people with very pressured vocations, and they suddenly feel like they can't do their jobs anymore,
Yeah.
and are finding that they're taking early retirement, they're having to take sick leave, they're having to do things that had never foreseen for their future, and that's such a loss to the workforce as well, because at that time where your skill set is at its peak, we really want to try and support women to be able to continue to offer that skill set and to be able to continue to engage with their work,
Yeah.
particularly if it's something that they get enjoyment from and satisfaction from.
And it must be quite frightening as well if you're having to do those things to counteract symptoms and you're unsure of why they're occurring.
Yes, yeah, absolutely. It can be really
Mm.
disorientating for women, I think. And I think sometimes they feel frightened to ask because they're
Mhm.
worried about getting the answer, oh, this is, it's early onset dementia.
Mm.
So they sort of shy away from asking that question, but it can get to a point where it's disrupting their quality of life to such an extent that they then come and see somebody like me.
Yeah. Oh. Oh, so that's really interesting. And if you think about the perimenopause,
Yes.
how does that differ? Is it very similar? Do you mind going into a bit more detail about that?
Yeah, so symptomatically, in terms of the systemic symptoms, it's very similar. It's
Mhm.
kind of a continuation, perimenopause into menopause and postmenopause. But what's happening in perimenopause is essentially it's the lead up to your period stopping and your ovaries going to sleep, in effect. And during that time, at the very beginning, it's a subtle disconnect that happens between brain and ovaries. So normally the brain and the ovaries, they run a very tight negative, what we call negative feedback loop. So they are constantly communicating with one another. The brain produces something called follicle stimulating hormone, or otherwise known as FSH, and the ovaries are a powerhouse of producing estrogen, progesterone, and
Mhm.
testosterone. And the follicle stimulating hormone that's produced by the pituitary, it does exactly what it says on the tin. It stimulates the follicles to produce hormones. And once the hormone levels get to a certain level, the pituitary gets this signal back to say, actually, we've got enough hormones now. You can now reduce the amount of FSH that you're producing, and then the ovaries quieten down again. And we continue in this cycle. And that's effectively what causes menstrual cycles, the
Mhm.
kind of waves of hormones, the peaking and the troughing. Now, in perimenopause, when that subtle disconnect starts to happen, when the follicles are starting to lose steam, we're just not got as many follicles left
Mhm.
in the tank. Um, the communication starts to subtly break down. Now, often women assume that once they're perimenopausal, they will see that expressed in their menstrual cycles, that the menstrual cycles will start to go awry, they'll start to skip periods, or
Mhm.
the duration of the cycle will change, etc. But actually, interestingly, often some of the systemic side effects of the perimenopause can predate the menstrual changes, which is what often causes some of the diagnostic confusion.
Okay.
And particularly in younger women in, say, their 30s or early 40s, they approach physicians to try and get an assessment done. And there's this assumption, often also amongst medical professionals,
Mm.
that if the periods aren't right, it can't be menopause. And that's not actually the case. And we know that the process of perimenopause can go on for up to 10 years in some women before their periods actually stop. So it can be a long process. And that's a
Yeah.
long time to suffer if you're not getting the appropriate treatment.
So could you go into a bit of detail about what are the impacts on a woman's body for with these changes?
Yeah, so what's going on internally?
Yeah, and what might that do to someone's general health?
Yeah, so that's the other really critical messaging about menopause is what's actually going on internally.
Mhm.
So women are often understandably focused on the symptoms,
Yeah.
but there is a wider message to do with what the effect of reproductive hormone deficiency is on the body internally. So we'll start with
Mhm.
osteoporosis. So we know that a lack of estrogen within the system leads to bone thinning. So we estimate that every year after a woman's periods have stopped, she loses about 2 to 3% of her bone density.
Okay.
So over a 10-year period, it's not unusual for a woman to lose up to a third of her bone density. So estrogen is really pivotal to keeping collagen within bones, and that allows the bones to maintain their tensile strength,
Okay.
which means that they are able to withstand forces better. So, what we tend to see in women who have osteoporosis, for example, which is significant thinning of the bones, is that they can have a small trip or a fall, which,
Mhm.
if it happened during their premenopausal years, they would have just jumped back up
Mhm.
from and been fine. Once they get to postmenopause, if they've had significant reproductive hormone deficiency for some time and the bones have thinned, it then results in a low impact fracture, or what we call a
Ah.
fragility
Mhm.
fracture. So I often like to use the chocolate bar analogy to explain osteoporosis to patients. So if you were to look at normal bone,
Mhm.
and you were to do a cross section through that normal bone, the structure would look kind of similar to what a crunchy bar looks like. There are small spaces within the bone, but it's a really quite a tight structure, and that maintains good strength.
Mm.
In a woman who has osteoporosis, the cross section would look more similar to what you'd expect, say, from an aero bar. So you'd have much bigger, wider spaces with that loss of bone trabeculae. And that's what then predisposes to fragility fractures. And fragility fractures, of course, can have a significant morbidity and even mortality attached to them, sadly. So recovery can be much longer at that point in your life. But in the longer term, it can affect your mobility, your functionality. And some people actually sadly never recover from a bone fracture, particularly if it's relating to a major bone like the femur. We often see it in the neck of femur. And women also get fragility fractures affecting their vertebrae as well. So the bones in the back, and what we see is loss of height. We often see premature curvature of the spine, and the significant thing about vertebral fractures is that women aren't always necessarily aware that they've had a vertebral fracture, that there's been some collapse in the bone there. Sometimes they can feel it and they get pain, and that pain can be distressing. Sometimes they don't. Sometimes they don't get that symptom, but there is breakdown and crumbling of the bones in the spine, and that's really problematic. So osteoporosis is of course something that we want to prevent, and replacing estrogen at hopefully an early stage rather
Mhm.
than waiting to get to a point where menopause is very progressed and they've been exposed to estrogen deficiency for a
Mm.
long time. It's much better to address it early if we can, to prevent that breakdown in the first place. So that's osteoporosis. Now, focusing in on the musculoskeletal system a bit further, of course, you've then got your muscles. Now, our understanding of the function of muscles is constantly evolving at the moment. So we now understand that our muscles effectively work like endocrine organs. So they produce chemicals called myokines, which are
Mhm.
very health promoting. They help with cognition, they help with vascular structure, they have lots of positive metabolic effects. Um, which in turn benefits your cardiovascular health. Now, what happens during the menopause is that we see a process called sarcopenia, which is
Mhm.
shrinkage of the muscles, but also a reduction in the quality of the muscles as well. And consequently, women are then lacking some of these myokines that would otherwise benefit their overall health. And as the muscles shrink, they lose strength,
Mhm.
and it impacts on long-term mobility as well. So actually it's really important for menopausal women to be looking to work on maintaining muscle mass and strength. And the best way to do that is through resistance training and maintaining a good protein intake. So we know that the protein requirements tend to go up around the time of menopause. So typically, we'll tend to say that we need to be aiming for at least zero point 0.8 grams per kilo of body weight of protein in the diet. Arguably, in menopause, it needs to be closer to 1 to 1.2 grams in practice, but some women practically find that quite difficult to achieve. So, to give you an idea, um, most women will probably need the equivalent of between 2 and 3 chicken breasts of protein per day to maintain their protein requirements, so that they're not in that sort of sarcopenic state. It doesn't, of course, need to be chicken breasts that they're eating. There are all manner of different types of protein, including those that can be gained from a plant-based diet. But having a focus on protein is important. And then the other aspect of things is resistance training. And the kind of government recommendation is that we try and do at least 2 sessions of resistance training a week, and we should be looking to exercise all major muscle groups.
Hmm.
Um, Within that. So for some women, that's going to be weight training. It might be using exercise
Yeah.
bands. For others, it might be doing Pilates. It might be dancing. It
Hmm.
might be walking on an incline. It's finding a way of moving against resistance. So that's all really important alongside the hormone replacement. So we know that there are estrogen and testosterone receptors within our muscles, and they're responsive to those, and that by maintaining estrogen and testosterone levels, we can help to maintain our muscle mass as well. So that's another kind of musculoskeletal implication of menopause. And then there's a wider picture to the change in body composition
Hmm.
that we see with women during menopause. So, as well as the shrinkage of the muscles, we tend to find that women are predisposed to gain visceral adiposity. So, that means the deposition of fat around the visceral organs or the internal organs. Um, and women in real terms tend to notice this as a change in their waist size. They often come saying, I seem to be gaining weight around my middle. Um, the internal impact of that is pretty significant because we know that visceral fat is what we call very metabolically active, which means that it's not just fat sitting there, it is interacting with the body, it is producing chemicals which, unlike myokines, which are very health promoting, these chemicals that come from the visceral fat are health damaging. So we know they are very pro-inflammatory.
Hmm.
We know that they increase the risk of high blood pressure. They increase the risk of high cholesterol levels, of insulin resistance, pre-diabetes, diabetes. That's all kind of on a trajectory. And they increase the risk of cardiovascular events. So things like heart attack, stroke, etc. And the other thing is that pro-inflammatory mediators can also increase the risk of certain cancers.
Okay.
So it is really important to acknowledge that in terms of the kind of future proofing of somebody's health,
Hmm.
the role that visceral fat has in terms of the sort of damage potential that
Yeah.
it has. So effectively, women are having muscle shrinkage, gain in visceral fat. That's the
Okay.
picture. And this impact on metabolic health as a result.
I understand. So it's the whole picture
The
of
whole
what's
picture.
yeah.
Yeah, exactly. The whole picture. And within that, so often when I have women come for their advanced menopause appointment, so I will be checking a lot of these components with them. So I want to know what their body mass index is, although that's only one part of the picture where weight's concerned. I want to get a sense of what their blood pressure is. So what we tend to find is that estrogen has a vasodilatative effect on blood vessels. That means it's a relaxant for blood vessels. So it keeps the cardiovascular system in a low, it becomes a low pressure system through that relaxation of the pipe work. And when you lack estrogen, you get a sort of contraction of the vessels and everything goes into a higher pressure system. So we see
Mhm.
that in a rise in blood pressure. So I would always check a woman's blood pressure or make sure she's had it checked recently, because that needs addressing
Mhm.
alongside the direct concerns regarding menopause if it's raised. And then the high cholesterol level.
Yeah.
Again, it's something that's quite important. We see that a lot because women come and they often have a new presentation of high cholesterol where they haven't had issues with cholesterol in the past. And it may be that a woman is maintaining a really healthy diet and a really healthy lifestyle, but she's still got high cholesterol levels. And the reason for that is because estrogen is implicated in the metabolism of cholesterol. And what we tend to find is that you get a rise in the total cholesterol level, and you also critically get a rise in LDL cholesterol, which is effectively like your naughty cholesterol,
Mm.
if you like. It's the cholesterol, which is specifically involved in plaque formation within the coronary and carotid vessels,
Mhm.
and it's the cholesterol that is involved in that risk of heart attacks and
Yeah.
strokes. So, to speak about cardiovascular medicine more broadly, um, during premenopause, we tend to find that heart attacks and strokes tend to be something that is often considered more of a concern for men. When women become menopausal, the rate of those events, those heart attacks and strokes, goes up fivefold. So it's a much bigger concern for them at which point. And replacing estrogen within the system is considered to be cardioprotective in that respect. Now, the only caveat to that is that we pretty much all the data that we have looks at women who are within 10 years of their period stopping. For those who have gone longer without periods, we lack the data to know definitively what the effect is on their cardiovascular system. So we don't know whether it's still health promoting in that respect. If you then decide to start estrogen many years since your period stopped, we don't know if it's still health promoting on that front, if we still get the same level of protection.
Okay.
So those are the kind of key tenets of
Yeah.
the health implications. There are of course more. It is such a rapidly developing area of
Mhm.
medicine, and we are researching more and more into different areas. One of the areas I sometimes often get asked about is dementia risk, because of these kind of often very prevalent cognitive symptoms that women come with. They worry about dementia. Where that's concerned, the data currently is quite mixed, and we're not entirely sure again what the
Yeah.
effect of HRT is on risk of dementia. But it is a significant concern for women's health. When you look again at what are the causes of mortality in women, dementia is really quite high up there.
Yeah. And I suppose that's why it is important that we do research which has a women's health focus because it's been
Yes.
lacking in the past a little
Yeah,
bit.
exactly. Yeah. And of course, funding is a huge part of
Mm.
that. But you don't get the funding until you get the awareness and the pressure on the
Yeah.
system to start funding it,
Yeah.
and doing more studies. And they need to be high quality studies as well. So
Yeah.
there is often people don't realize that there is a real hierarchy to the quality of research. So the top level is considered what we call a randomized control trial. And if we have big randomized control trials with large numbers, we consider those to be much more robust than some of the smaller kind of retrospective studies, for example. So it's confusing for the general public because if they haven't been trained in statistics, how would they know
Yeah.
the difference between one set of research and another?
Yeah.
And that's where, relying on specialists to guide you in that and to guide you through the evidence is really important.
Yeah. And I suppose this leads really well onto the treatment. So I wonder if you wouldn't mind spending some time talking about the treatment of the menopause and perimenopause.
Yeah, sure. So a lot of what I do, unsurprisingly, is provide hormone therapy for women, so putting the hormones back. Um, I preferentially tend to deal in body identical hormones. So these are hormones that are essentially like the new generation of HRT, if you like, and they are very cleverly engineered to exactly mimic the natural hormones produced by the ovaries down to a molecular level.
Mhm.
So your body considers them very familiar. It processes them in a very similar way to as how it would process its normal hormones, and they're considered to be sort of the most physiological and gentle form of hormone replacement that we have available. And that is very different to the old forms of HRT that we had historically. So we used to have very much higher dose synthetic hormones, which did have small increased risks attached to them. For example, small increased risk of breast cancer with certain synthetic progestogens, and a small increased risk of clots as well. Whereas body identicals, we've worked around a lot of those risks, and actually it's considered extremely safe, which is why it's sort of like the gold standard these
Mhm.
days. So, in terms of body identical HRT, the form that would take would be a prescription for both estrogen and progesterone separately. The reason that we prescribe the hormones independently is because it gives us better control over the individual hormone levels and it allows us to tailor the care better.
Mhm.
And the body identical progesterone, the most common brand of that in circulation is Utrogestan. It's micronized progesterone and it comes as a little spherical capsule. And we advise taking that in the evening time before bed because it has a gentle sedative quality to it, which actually for many women is quite helpful because they
Yeah.
often suffer sleep disturbances during menopause. Now, there are different regimes of progesterone depending on where you are at in your menopause trajectory. So, if you're in perimenopause and you're still having periods, we tend to sequence the progesterone. So, that means that for the first 2 weeks of every 4 week cycle, you won't be having any progesterone at all. You'll just be having estrogen. And then for the second 2 weeks, the progesterone gets added in. And the idea is that either towards the end or at the end of that progesterone course, you'll have a withdrawal bleed, a bit
Mhm.
like a period. So you will continue to have a cyclical bleed. And the reason that we don't push to put you on a continuous regime when you're perimenopausal is because if we did that, the likelihood is that you would probably get quite erratic
Mhm.
bleeding patterns. So we just maintain this regular cycle of bleeding. And we do that for at least a year, sometimes for longer. We don't tend to exceed 5 years of
Mhm.
a sequential regime of progesterone. Eventually, we like to move everyone onto what's called a continuous regime of progesterone, which means that you would be taking progesterone every single day throughout the month without a break. And the benefit of that is that it optimizes the protection of the womb lining in the long run. Because to explain, the main focus of progesterone therapy is protecting your womb lining. So if we give estrogen therapy in the absence of progesterone to a woman who's got an intact womb, what happens eventually is that the womb lining will start to thicken,
Mhm.
become unhealthy, and then you can get abnormal cells. And the worst case scenario is the development of what we call an endometrial cancer. So the progesterone very cleverly blocks that effect, and we're always looking to get the best level of protection that we can for the womb lining in that context. Now, in terms of the estrogen component, we give that through the skin, the body identical estrogen. And the reason for that is because if we give estrogen through the skin, we entirely bypass the clotting cascade of the liver. And so there is therefore no increased risk of clot. So it's safe even to give in patients who have clotting disorders.
Mhm.
And that generally will take the form of either a patch or a gel. There's also spray available. And if you were opted for a patch, that is what we call modified release. So it means that it's like a matrix structure to the patch and it releases the same dose of estrogen every hour that ticks by. So it gives you a nice even level of
Okay.
estrogen. And you apply your patch to what we call hairless skin
Mhm.
below the waist. In reality, we have hair all over our bodies, but we're looking for areas where there's less hair.
Mhm.
So often women will apply it to their sort of low tummy area, their buttocks, their upper thighs, and then they change the patch typically twice weekly. So it's quite good for women who have a busy life, um, or who maybe struggle to remember things. It's helpful. So that's the patch. Sometimes it can leave a bit of a sticky mark after you've applied it, and using baby oil sometimes helps to remove the
Okay.
sticky mark afterwards. In the alternative, for women who don't want to have a patch, they might opt for a gel, for example. My preferred gel brand tends to be Estrogel, although there's also Sandrina
Mm.
available that comes in a sachet. With Estrogel, it's in a pump dispenser, and I would just prescribe a certain number of pumps. Um, and it's really easy to make dose adjustments with Estrogel, but it's a daily application, unlike the patch. So it's a little bit more admin heavy, but often
Yeah.
women like it. They feel like it's part of a sort of natural beauty routine for them. And it takes a few minutes to dry once it's been applied. What you do need to remember with your gel is that you cannot bathe. Um, Wash, swim for about 2 hours after you've applied it to give it time for that product to absorb. Whereas with the patch, you can bathe, wash, swim, etc., do all of those things with your patch on.
Okay.
Sometimes there is a need to use synthetic progestogens in place of the body identical progesterone. One example of that is in women who may choose to have a Mirena coil. So Mirena coils are also considered to be really safe,
Mhm.
a really safe component of HRT. And it's a coil that sits within the womb and it releases the progesterone locally at the level of the womb. You get very little in the way of systemic absorption by comparison, for example, to a tablet form of progesterone. And Mirena are very good at producing a very high level of wound protection. They're very good at thinning the womb
Mhm.
lining down. They're sort of a belt and braces approach where that's concerned. And they have the additional benefit of the fact that they provide cross contraceptive cover as well.
Okay.
And about 70% of women tend to be what we call amenorrheic on a Mirena,
Mhm.
which means that they don't have any periods at all with it. There are some women who will have erratic bleeding on the Mirena, and it's difficult to know until you've tried it what camp you're going to sit in.
Mhm.
But certainly, a lot of women quite like the idea of having no periods.
Yeah.
So that can be quite nice too. So you would just sub that in and you'd use the Mirena in place of the body
Mhm.
identical progesterone capsules. So that's an option. Some women have need for a synthetic progestogen tablet, but that tends to be in specific circumstances, and we would counsel through that if that was felt to be appropriate. It usually relates to kind of bleeding pattern for the most part. But yeah, so those are in simple terms are the kind of options that are available hormonally. We do have the option to add in testosterone therapy as well. So that's something that's becoming increasingly popular amongst women, and they're asking more and more about it. So testosterone is off license currently in the UK. That's not because of any safety concerns relating to testosterone therapy. It's because there's no pharmaceutical company who's taken on that license at the moment. Um, and there are various medications that we regularly end up using in the UK off license. In practice terms, we've got quite a lot of experience of using testosterone replacement, and we often find it's really effective for a lot of women. In fact, for some women, it can be really game changing.
Mhm.
And we think that is down to the fact that maybe they have a bit more of a density of testosterone receptors in certain parts of the body.
So what are the kind of symptoms that testosterone can help with?
So testosterone replacement has a really good evidence base, a really well established evidence base in helping with libido.
Mhm.
So we know it can be really effective at helping with the biological drive to want to have intercourse. Um, NICE tends to recommend using it once a patient is already established on HRT, if they're still having residual issues with libido, which isn't being addressed by the estrogen replacement, because of course estrogen itself can help with libido
Yeah.
too. Um, However, there are some large scale surveys that are available now, and there's certainly a plethora of anecdotal
Mhm.
information relating to other benefits that can be gained from testosterone replacement. And in practice, I tend to find that it can be really helpful for women's energy levels. So, if they're suffering badly with fatigue, it can be really helpful with cognition and sort of mental sharpness. And often it can also help with anxiety as well and kind of
Okay.
self confidence, which can often be lacking during menopause.
Mhm. Are there any side effects that people experience commonly?
Yeah, so if we break it down, I'll start with side effects relating to sort of your traditional HRT with your
Mhm.
estrogen and progesterone to start with. So, bleeding is common. So, we often have unscheduled or unexpected bleeding occurring within 3 months of starting on HRT or 3 months of making a dose change. That's very common. And we generally consider that to be permissible unless the bleeding is particularly heavy, where you're flooding through sanitary wear or having large clots, or if it's lasting for longer than a sort of normal period-like duration. In those instances, we'd always want to know about it. The other thing is that you can get breast tenderness in the early stages of being on HRT or a dose change. And generally, this will settle down on its own over the course of a few weeks, sometimes up to a few months for some women. But you can use evening primrose oil or starflower oil to try and settle it down
Mhm.
sooner. Where testosterone is
Mhm.
concerned, um, generally speaking, we tend to find that it's usually very well tolerated. And a lot of that is down to the fact that we do testosterone blood test monitoring. So we monitor the levels to make sure that you are pitched within normal female range. Okay, so women have about an eighth to a tenth of the circulating amount of testosterone of a man. So we want to keep it at that point.
Mhm.
We're not looking to overshoot. And through the monitoring, we often are able to avoid any side effects. But having said that, I always make women aware that because testosterone is a topical treatment, so it comes as either a gel or a cream, which you apply daily to your buttock or outer upper thigh area. If you keep hitting the same spot over and over again, eventually you can have slightly thicker, darker hairs growing at the site.
Okay.
So I usually say try and alternate sides or move around the
Hmm.
point at which you're applying it slightly. And that often helps to manage that. In terms of more systemic side effects, women worry about hair growth, they worry about acne. So the only few cases I've had where that's been a problem for women has usually been where they're women who have had slightly higher natural androgen levels as a
Okay.
starting point. Maybe they've been a bit predisposed to acne in the past, or they've had some unwanted hair growth elsewhere before. But generally speaking, as a rule, I'll always baseline test those women
Hmm.
before starting to make sure that we're not going to be in a position where we're going to overshoot and make anything worse.
Okay.
But we never look to go anywhere close to the kind of circulating levels of a man where you'd expect to get sort of voice changes or growing
Hmm.
a beard.
Yeah. And if someone was to opt to not have hormonal treatment, what are
Yes.
the options for those people?
Yeah, so there are plenty of different options that you can look at which are non-hormonal. There's a very sort of limited number of cases where hormones aren't an option. But having said that, for some women it's their preference not to have
Hmm.
hormones, and that's absolutely fine too. We know that lifestyle plays a big factor in terms of impact of symptoms and quality of life during menopause. So we always encourage a clean diet, reducing intake of alcohol, caffeine, exercising regularly, looking after your body, getting a good sleep routine in place. All of those things can help in terms of managing. There's some evidence that CBT can help in terms of managing hot flushes and sometimes the emotional effects of the menopause as well. So, for those who don't know, that's cognitive behavioral therapy. So, that's a type of psychological therapy. In terms of medications, so there are medications available. There's a group of antidepressants called selective serotonin reuptake inhibitors. Interestingly, I don't tend to find that these are that helpful in terms of the emotional effects of the menopause, but sometimes they can help with vasomotor
Hmm.
symptoms. So that's your hot flushes and your night sweats. There are other, what we call neuropathic medications like gabapentin, for example, which can be used to help with hot flushes and night sweats. But these do tend to have quite a strong side effect profile. So sometimes the side effects can often outweigh
Hmm.
the effect of the menopausal symptoms in the first instance. So we have to think quite carefully about that and
Yeah.
how you dose adjust it. There are more modern sort of forms of non-hormonal treatments. You may have heard of the brand Veoza.
Hmm.
So that works on the thermoregulatory center in the brain. The current guidance is that we do liver function monitoring for patients who want to explore that option because it can sometimes affect liver function. So that's something important to be aware of. In terms of more sort of homeopathic options, um, anecdotally, some women do find certain treatments that they can get over the counter helpful, whether that be supplements or whether that be
Hmm.
alternative therapies. Do remember these aren't regulated areas in the way that sort of medical practice
Yeah.
is regulated. So we can't vouch in the same way for the kind of safety and efficacy.
Hmm.
And so, generally speaking, I tend less to recommend those options. But at the same time, if somebody is choosing to use something and they're finding that they're gaining a benefit from it, then unless I've got specific safety concerns
Yeah.
about it, I certainly wouldn't be dissuading them.
Is there a role that you feel for supplements at all?
Yeah, so I think there is. So vitamin D
Hmm.
is well established in being helpful. So vitamin D, we generally manufacture vitamin D in the body with the use of the UV rays from sunlight. In the UK, of course, we are very lacking in
Hmm.
exposure to sunlight, and often sensibly people are trying to stay out of the sun more these days because of the melanoma risks, etc. So supplementing vitamin D is important. It helps with mineralizing the bone, so it's the mineral content of the bone. So again, it's contributing to that bone strength that we
Yeah.
spoke about earlier. So I generally recommend that for all menopausal women that they tend to take 10 micrograms or 400
Hmm.
international units of vitamin D daily throughout the year.
Okay.
So there's a good evidence base for that. Some women also find that magnesium replacement is helpful. It can benefit sleep. It can also sometimes benefit symptoms of anxiety as well. It can be quite neurocalming.
Hmm.
So I usually recommend either magnesium citrate or magnesium glycinate of a dosage of 100 to 400 milligrams daily for that. There are other supplements that some women find a benefit from. So some women like to use collagen supplements to help with their skin and their hair during menopause. And there are some RCTs that relate to collagen supplementation and suggest some benefit. And there's been suggestions where hair is concerned that it can help with reduction in shedding and
Okay.
the quality of the scalp as well. So it
Hmm.
can help with hair growth. Um, and the other thing is that creatine is sometimes used by women, and it can help as a bit of an adjunct if you're trying to maintain your muscle mass as well, help with the recovery process from gym work. So there are various supplements that can be
Hmm.
helpful. The market is awash with them, however,
Hmm.
and do be a little bit cautious if you start signing up to lots of different supplements that you're not getting lots of overlap,
Hmm.
because sometimes they're containing some of the same vitamins, and there can be a real risk of vitaminosis if you're taking lots of
Yeah.
multivitamins and sort of overlaying them.
I mean, you've gone through such a lot of information. I just wondered what is it that you enjoy about menopause care and women's health?
So I think there are multiple things really. I love looking after women. I don't know specifically what it is about the fact that I just love the
Hmm.
consultations that we have. I feel that I really connect with women as my patients. Um, and I feel that in my current specialty, I make a real difference to my
Hmm.
patients, and that is massively satisfying.
Hmm.
And I love being able to give them the time and having the continuity there of care with them.
Hmm.
So I love bringing women back and seeing that real change in their whole demeanor often,
Yeah.
and in knowing about the changes that have been made to their quality of life. So that's really lovely. And I think it's also the fact that it's that vulnerability that you touched on
Mm.
before as well. It's the fact that you're caring for people at a point where they feel vulnerable and they really
Mhm.
need that care. And with women's health being so sort of underfunded and under researched in the
Yeah.
past as well, um, it needs more input, not less. And it's an exciting area from a medical point of view as well, because it's evolving all the time now and we're learning more and more. And that is so stimulating. And I love the continuous learning that comes alongside that.
Yeah. And what do you see on the horizon for your clinic? What are the plans?
Yeah, so I love what we're doing at the moment. I'm one of these people that just I'm a bit of a glutton for punishment when it comes to education. I actually love um, postgraduate learning.
Mhm.
So I'm always looking to add new layers to my qualifications and my knowledge. And for me, medicine is a lifelong learning process. Um, so any way in which I can perfect what I'm doing, I'm going to do that.
Mhm.
But in terms of new services, so I'm shortly due to start training in aesthetics as well.
Mm.
So it's often an area which I was a bit nervous about introducing it in the first instance, because it's not traditionally something that's discussed that much in the
Mhm.
context of menopause. But it's often something that women worry about a bit, and they
Mm.
worry about their skin and their hair and the changes on their weight, etc. And and actually, I think allowing women that space to kind of look their best as
Yeah.
well often has a nice effect on their self-esteem. And so I feel that I want to kind of support that really.
Mhm.
um, and it's nice for me to have that practical skill that I'm doing in clinic as well, because
Yeah.
I love using my hands,
Mhm.
and I'm quite a perfectionist, so I think I'd be quite suited to doing that work. So I'm training with interface aesthetics. So as it happens, the founder of that academy is an old training pal of mine,
Mhm.
James Olding, and he recently won the top aesthetics practitioner of the year.
Mhm.
So he's doing amazingly, and he's
Mm.
of a Max Fax background, so he's a Max Fax surgeon for the NHS as well. So I'm training with his
Mhm.
academy next month, and
Okay.
then adding in the service, which will be yeah, just a really lovely thing to add in alongside.
Yeah, that sounds very exciting.
Yeah.
So, I suppose I just wanted to finish by saying thank you, Katie. It feels like it's been a real luxury to talk in such depth about the menopause. So, thank you for inviting me here. It's been a great opportunity.
No, thank you. Thanks for coming and asking the questions. It's been really nice to have the chance to talk about what it is that I love.